Well, it's nice and quiet there. Quieter than my house where people are honking the horn outside. All right, I think we'll go ahead and get started. We have, I think, a quorum here. Welcome, everyone, and thank you so much for joining tonight's Empire Urology in-service review. We're really lucky to have Dr. John Sfakianos from the Icahn School of Medicine at Mount Sinai joining us tonight to host his lecture on bladder cancer. Dr. Sfakianos is a true New Yorker. He did his residency at SUNY Downstate, followed by a fellowship at Memorial Sloan Kettering Cancer Center. He's an assistant professor of urology at Mount Sinai, and he has been awarded the teaching award several times at Mount Sinai. He is very active with resident teaching. He leads the daily Thursday morning conferences for the residents, and I'm very excited to have him giving our lecture today. So John, I'll turn it over to you, and we'll try to get through the lecture in about 40 minutes, leave some time for in-service questions, and then I'll moderate any Q&A that shows up in the chat.
All right, Alex, thank you very much for that introduction. So I will probably get through the material in less than 40 minutes. You know, having or been running this kind of conference for our residents over the last several years, I'll try to highlight what I think are the important concepts that you need to know from the guidelines, and then just about cystectomies and metabolic derangements. A lot of the derangements, cystectomy complications, and so forth do require some memorization, but a lot of what, you know, I always yell at the residents about is understanding. If you understand the disease, if you understand the concepts, then the questions and so forth become easy, because you can sort of go through that step-by-step processing because the knowledge is there. I'd like to make this very interactive, so if I say something stupid or say something wrong or say something that's not clear, please just interrupt me, or you know, throw something up in the chat and Alex can interrupt me. And if there are questions or things that I don't cover, please let me know. But I do have some questions at the end of this. You know, there are usually 1 or 2 questions every year on non-muscle invasive. A lot of it does come from the guidelines, which are important to just kind of recognize. I throw this slide up first because with bladder cancer, you kind of one and one go hand in hand. You need to know what the hematuria workup is, because that's usually where the majority of our bladder cancer diagnoses come from. So this is the 2020 Hematuria Guidelines, which have taken a fairly drastic change to what we know from the past, because similar to our non-muscle invasive bladder cancer, it's all about risk stratification and things like adding renal ultrasound, which I would say a lot of urologists were doing anyway, but you know, obviously outside of the guidelines, but now are in the guidelines, and it's important, especially when you're thinking about how to surveil or even how to diagnose upper tract disease. So it's important for everybody to just sort of look at this guidelines. It's on the AUA website. There was a press release about it, and then just go through this. And really important, what I like to just highlight are the low risk and intermediate risk patients, which obviously are microscopic hematuria, fairly low number of RBCs, no real risk factors. You know, we are sort of doing risk stratification and shared decision making, in essence, with these patients about how often and what exact tests to get. So renal ultrasound is now part of these guidelines, and it's important to make sure that you understand that. And obviously the patients who are high risk, gross hematuria, very high microscopic hematuria, have risk factors, tobacco use, carcinogen exposure, so forth. You basically are going into the same workup as previously done before. But what you kind of do see in all these three are the cystoscopy, and the cystoscopy is a very important part, not only for questions, but just managing your patients. So cystoscopy, TRBT, is by far one of the most important technical aspects of bladder cancer patients. And, you know, if you listen to a lot of the bladder cancer surgeons, it's not as easy as you think. It is technical, and it is the difference between what I would say proper treatment and improper treatment, and it could make a huge difference in outcomes. These are a lot of excerpts from the actual guidelines that are on the AUA net and the AUA clinical guidelines for non-muscle invasive bladder cancer. I'll highlight what I think are the most important, not only for your in-service exams, but also just for treating these patients. The one important aspect that I try to voice over and over to all my residents is complete visual resection of the bladder tumors. And this is obviously very high up in the guidelines, that if whatever tumor you have present, it is extremely important, if technically feasible, to try to do a complete resection. In some instances, you may have to bring a patient back into the operating room once or twice or even 3 times to be sure that you constantly are that you're sure that you have resected all the tumors, but it should be on the forefront that you're going in to every patient's bladder with the idea of removing every visible tumor. And you shouldn't just take the approach, I got a good enough of a biopsy, I'm done, let's see what the biopsy shows, but rather that you need to resect everything. Especially if a bladder sparing approach is being considered, that's obviously important, but the key part of this is to make sure that you understand the variant histologies. Variant histologies are important in your questions, and so when you're taking these written exams, it's very important to pay close attention to the STEM and make sure that you understand if there is a variant histology present, things like micropapillary, neuroendocrine, small cell, squamous cell. Those are important concepts to remember. It's also very important to make sure that you understand if these are urothelial with the variant, or these are pure variant histologies, because that does make a difference in how to treat the patients. And there's always, at least on the SASP questions and even on the exams, questions about small cell, muscle invasive small cell, and how to treat those. And those patients obviously get different chemotherapy regimens than the pure urothelial or the urothelial with neuroendocrine features. So very important to remember those. So the most important part of restaging TURBTs, it's actually important for BCG function. And you'll see this in almost any data that you get about BCG or intravesical BCG. It works best with minimal residual disease in the bladder. So if you have a high volume patient and you do an incomplete resection and you give BCG in the adjuvant setting to that patient and you expect all the tumor to be gone, it is very unlikely that that's the case. Again, in the question stems, make sure that you understand, what the next steps are. They can easily hide in that question stem that you did a TURBT and sampled the bladder tumor and it is TA high grade, and what are the next steps? And intravesical BCG, intravesical chemotherapy, restaging TURBT, et cetera, et cetera. It is important to make sure that you get the restaging TURBT, and it is it's important to do the restaging TURBT to get complete resection of the tumors, and it is extremely important to do restaging TURBTs in the intermediate high risk patients. Obviously the PTA high grade greater than 3 centimeters, or patients who have T1 high grade, they should all get resected within 4 to 6 weeks. So some key points that I think are extremely important. Adjuvant chemotherapy. So that's gemcitabine, valrubicin, doxorubicin, docetaxel. Which one did I miss? Gemcitabine, mitomycin, valrubicin, or docetaxel. They kind of get all clumped up into one. For the purposes of your in-service, you can't assume one is better than the other because there's really no data. A lot of times they will just lump them together as intravesical chemotherapy. Obviously, mitomycin is the one that is best known and is the one that's may show up the most on a written exam in terms of one of the answers. So just be aware of that. The idea is that it improves recurrence-free survival because it actually will try to prevent seeding from anything that may be floating around in the urine, but also that if you do miss small amounts of disease, chemotherapy is actually toxic. And if you go back to the initial studies with chemotherapy, the studies actually did leave a portion of tumor behind in the patient's bladders, and then gave the chemotherapy and actually saw complete responses in those tumors. So different to BCG, chemotherapy may be able to actually get rid of tumors if there's some left behind, and that's actually been shown with the adjuvant studies, whether with gemcitabine or mitomycin. But especially for the actual in-service questions, you have to be very cautious again in the stem of the questions to when not to give it. Things like hematuria. So if the catheter goes in and there's still some hematuria, you should not be giving the chemotherapy. Suspicion of perforation, any suspicion of perforation. And the way they get you on the actual exam with suspicion of perforation is by telling you that you do an extensive TURBT. So if you see those words, things like extensive TURBT, suspicion of perforation, those are, or I should say, extensive resection is really kind of their way of saying that there may be suspicion of perforation that you just can't see because you were focusing on the TURBT so much. So for those purposes, you really should be cautious about giving the adjuvant therapy if there are things like extensive TURBT on the stem. Other important patients are the patients with history of non-muscle invasive bladder cancer with a normal cystoscopy and a positive cytology. This is a common testable question. The old, I would say old school, without blue light cystoscopy, you would do upper tract imaging, selective cytology, biopsies of the prostatic urethra, random biopsies. But really important in today's world is to consider the blue light cystoscopy. And when available, and if that is a question, in this case, it should probably be one of the first things that come to mind as an answer, because really the blue light cystoscopy, one of the things that have been proven with blue light cystoscopy is the ability to improve diagnosis of carcinoma in situ, which is obviously something that you worry about when you have a normal cystoscopy but a positive cytology. And similar to what we spoke about before, really the variant histologies are things that you need to be very cautious about and make sure that you are, if invasive, if high risk, really should be offering more aggressive therapy in those patients. I mean, the favorite testable question in this case is really the micropapillary patients. And you should just be making sure that in the question stem, you're understanding what that is. So once you've done your cystoscopy and your TURBT, your risk stratifying patients, obviously this is a memorization table. You need to know, what is what and what falls into each category. In the way that I remember this is basically low risk. I memorize low risk, I memorize intermediate risk. Everything else is basically high risk. Things that you have to be very cautious about are the TA high grades, less than 3 centimeter, greater than 3 centimeter. And any recurrent high grade TA automatically bumps you up to high risk. And that's just something that you need to be cautious about. The less than or greater than 3 centimeters is actually a point of debate in the literature and amongst urologists. The European guidelines do not have that separation. But here in AUA in the US, we do make that, and the SUO, we do make that separation. So very important to remember that. And again, variant histologies, BCG failures, T1 high grade, NECIS. I can't really teach this. You have to just understand this and memorize this. And if you understand the disease processes and which ones are aggressive and which ones are not aggressive, then this kind of doesn't become a memorization, but it's like, okay, T1 high grade, that's a bad disease, so it's high risk, and so forth and so on. So that's the way to do it. This is a really great summary and table that Dr. Kamadal published in the Journal of Immunotherapy of Cancer a few years back, because it basically very nicely breaks things down. It kind of helps you differentiate low, intermediate, and high risk, and then gives you an idea of how you should actually treat patients. So really, again, fairly newer guidelines, but what we do know is that low risk patients, so TA low grade, like we said, pun lumps, there is an argument about changing how we describe, or the characterization of pun lump to low grade cancer or not, but basically pun lump, TA low grade, you give that single adjuvant therapy, but then that's it. You just watch those patients. And if there is a recurrence of those patients, then they get bumped into intermediate. But for the initial diagnosis, you actually call those patients the TA low grades, and you just watch them. The intermediate risk patients, you can just forget about this, but really the intermediate risk patients, and according to the guidelines, which is extremely important from this perspective, we're talking about BCG with 1 year maintenance. So in the actual test, you have to be able to differentiate between 1 year maintenance and 3 year maintenance for intermediate risk and high risk. Because of the BCG shortage, and if you read the NCA, the AUA guidelines, you can actually choose for intermediate risk either BCG or chemotherapy. And the chemotherapy, again, does not necessarily have to be mitomycin, but that is the one that's most commonly referred to, but it could be any one of the other agents or combination agents, where in the high risk patients, you really should be answering BCG. And if you do not have the option of BCG, and it is a patient that is fit for cystectomy, that should be your answer. The key points for intravesical therapy, again, you should do it within 24 hours of resection. Again, 24 hours is important to make sure you remember that in your question stems, answer choices, pay close attention to that. Intermediate risk, like I was just saying, chemo or BCG, but you should be talking about maintenance BCG or chemo for 1 year. So very important that we, in the guidelines now, talk about doing maintenance chemo as well as maintenance BCG for 1 year for intermediate risk patients. So if you choose chemo, there is an option for doing chemo plus chemo with maintenance for 1 year. That should be your answer choice. Who's doing that? Is that you, Alex? That's nice. High risk patients, again, it's BCG plus 3 years. Unfit, you can consider a couple other things that I'll go into a little later, but fit patients, if you do not have BCG, I can see them doing this now because we're in another shortage, giving you a question of a high risk patient. You can't get BCG, what are the treatment options? You need to understand if that patient is fit or unfit for cystectomy. If fit for cystectomy, you get a cystectomy. Unfit for cystectomy, then we'll talk about things in the next few slides. Other cautionary tales for BCG, you may, and there's been plenty of questions about BCG side effects. And really the most important part of the BCG side effects is the systemic infections. You can get active tuberculosis, right? Because this is heat inoculated, but this is still a live vaccine or a live attenuated, a live bacterium. So you can get tuberculosis or active TB. The risk of getting it is very low, less than 1%. Knock on wood, I have not seen it in my career, but others have. And so if you have a patient, that you gave BCG to, and then you see signs and symptoms of shortness of breath, fevers, cough, fatigue, malaise, altered mental status, those types of things, you obviously need to keep in the back of your mind that that patient may have systemic infection. And you need to do the appropriate either treatment and or workup for that patient. The do not give scenarios are also commonly, favorite scenarios to be questioned about. Things that so the do not give is really in the back of your mind should be, will this patient have an increased risk of getting systemic infection with BCG, right? If you think about it that way, then you should look at your questions or your answers, and then say, okay, which one of these is the one that risks systemic infection the most? And obviously a traumatic Foley, because that may cause hematuria, or if the patient has active hematuria, you have open blood vessels, the BCG can get into the circulation and obviously cause problems. The immunocompromised patient, and this is always, to me, I've looked at all the different types of questions, and I can never really understand what the answers for some of these, because transplant patients are fine. You can give them, they're immunocompromised, but they're not necessarily fully immunocompromised. Patients that are on low dose steroids, you're probably fine giving BCG, but patients who are on high dose steroids, you don't want to give BCG to. Patients who are on cytotoxic chemotherapy and have the risk of being neutropenic, you don't want to give BCG to. So these immunocompromised questions become a little more tricky in terms of how immunocompromised is the patient, right? Just because the patient is on steroids doesn't necessarily mean they're immunocompromised if they're on a very low dose daily compared to like a high dose pack. Things like a patient who has COPD, who has an exacerbation and was just started on very high dose steroids, but will be tapered. You don't want to give that patient BCG while they're on the high dose steroids. You want to wait until that patient is tapered. That's kind of something to just think about when you're looking at those questions. And the obvious, the global incontinence, if there is no surface contact, if the patient, if it all just leaks out, then there's no reason to be giving that to the patient. And this is one of my favorite figures because it's kind of goes into the immunology of BCG, which is what I'm studying. So surveillance is also a bit more complicated now. Because surveillance has changed along with the risk stratification, rather than sort of being the same for everybody, it is based on risk stratification. So if you understand the risk stratification, you understand how aggressive you want to be with your surveillance. Obviously, the low risk patients, you want to be a little bit less, aggressive with, and more, the most important part of the low risk patients, and again, where they can catch you with the different stems and so forth, is that you should not be doing cytology according to the guidelines for low risk surveillance. It should just be cystoscopy 6 to 9 months. If negative, so everybody gets it within the first 3 to 4 months. If negative, then low risk patients should get it 6 to 9 months. If that's negative, then annually for 5 years. At the 5-year mark, it's basically shared decision making with the patient. The intermediate risk patients are a little bit more aggressive. You go 3 to 6 months for 2 years, 6 to 12 months for 3 to 4 years, and annually thereafter. There is really no stopping according to the guidelines for intermediate or high risk. And then the high risk patients, you're every 3 to 4 months for 2 years, 6 months for 3 to 4 years, and then yearly after. The high risk patients are basically what we all learned, or what I learned used to be the normal for everybody, but is really now just a normal for high risk. Again, it's a little bit of a memorization, but also an understanding. If you kind of understand the risk groups, then you kind of, and you can put your patient into a risk stratification or a risk, but one of these buckets, you can easily answer or pick out the answer from for the question by basing what the risk stratification is. And now we go to what happens when BCG fails. This is obviously a very complex, not very straightforward patient scenario. Again, for your test questions, this would be somewhat easier. But the most important part of this, and a lot of urologists and a lot of people who take care of bladder cancer have sort of gone away from this, but the data to actually support this, which is that patients who fail a single induction BCG can be offered a second course of BCG, and this is sort of what always has been in the literature, has now, I wouldn't say been validated, but there's more and more data coming out to actually support this, with a durable response around 50% after a second induction BCG. And then this is a paper that recently just came out, multi-institutional, with the Hopkins group leading it, really showing that in patients who have a second induction BCG, you get a durable response out a couple of years in the 50 to 60% range. And so for the purpose of your actual questions, because this is part of the guidelines, you really should be thinking about a second course of BCG as your answer. And you also have to make sure you remember that an adequate BCG is 2 induction courses, or 1 induction course plus 1 round of maintenance. And then anything that you have a recurrence within 6 months basically means that the adequate BCG has failed. So again, a little bit of a definition, but clinically, this is what makes most relevant sense. So take the time to understand this and understand that the severity of disease, what the severity of disease is, but remember, second course of BCG, really important for your test questions. The T1 high grade recurrences after induction BCG should, these patients should, if fit, should really be pushed towards cystectomy. But again, a second course of BCG is an option. And then intermediate or high risk patients who've gotten adequate BCG, who have a recurrence within 12 months, who are unwilling or unfit for cystectomy, what I kind of mentioned before, you really should be considering intravesical chemo either as a single agent or in combination. The gemcitabine docetaxel is the common agents that we use now. You may see it on your exam. I doubt you will because it's relatively newer data. But just think single agent chemotherapy as an option for these patients versus immunotherapy in the carcinoma in situ cohort, and I'll talk about that in a second, versus clinical trial. Clinical trial has been kind of coming more and more as an answer. So just make sure that if you see clinical trial, don't just sort of say that can't be the answer, because in this population, that might be the answer. So this is sort of the schema for Keynote 057, which basically was a BCG unresponsive study using pembrolizumab as a single agent, systemically given. It was a phase 2 study that basically showed a 20% 12-month durable complete response rate in patients who have carcinoma in situ. And for that reason, it was given FDA approval earlier this year. So going back to this scenario here, if you have a high-risk patient who's received adequate BCG, who has a recurrence within 12 months, one of the options is to give pembrolizumab to this patient. And this may actually show up on your exam, so make sure that you understand that. The rest are clinical trials, and they may not necessarily, if it's not one of the options. And very importantly, make sure that the patient is fit, for immunotherapy as well. And if they may give you a patient that for whatever reason is immunocompromised or just has had previous immunotherapy for this and has had a bad reaction, make sure that you don't give that to the patient, but consider clinical trial or the intravesical chemo. Radical cystectomy for the non-muscle invasive cohort patient. The important concept here is that it should really be the last resort for TA low-grade or intermediate risk patients. So I'm actually starting with my last bullet point here, because you really should try to stage the TURBTs, try the intravesical chemotherapies. But in all reality, this should be a limited attempt. So do not go 3rd, 4th, 5th line intravesical therapies for patients, because even TA low-grade patients will end up, or can, right, about 5% of patients who are low or intermediate risk can have metastatic disease, and they can die of their cancer. So you attempt stage TURBT, so it may be once and maybe twice, I usually say if I have to go back to the OR a third time and I still can't get all the tumor out, it's a failed attempt. And you can try BCG, you can try chemotherapy, you can try a clinical trial. Again, 3 is my magic number. Once we've tried 3 different agents or attempts, then you really should try to push the patient to cystectomy. And that is more of a taking care of your bladder cancer patient, real life, than an answer to the an answer to your questions on your in-service. But that is part of the guidelines and it can be tested and important for you to know. Otherwise, high-risk patients who are fit for surgery with persistent T1 high-grade cancer, if they have T1 high-grade CIS from the get-go, if they have some of these rare histologies that we spoke about, lymphovascular invasion, which is again a soft indication, but it is part of the guidelines, those patients should really go for cystectomy. Again, persistent high-grade T1 disease is after adequate BCG and have a recurrence within 6 months. Patients who have a high-risk disease, who are persistent or recurrent disease within 1 year following treatment with adequate BCG, those patients can also be considered for cystectomy as more of a curative attempt, but obviously can also get other intravesical therapies. It is very important to understand the concept of upper tract surveillance as well as upper tract initial imaging for diagnosis. You 100% have to get it with the initial diagnosis, but very important to make sure that you understand that in patients who have intermediate or high-risk patients, even if they're NED, 1 to 2 year intervals, you can continue to get upper tract imaging, and you should continue to get upper tract imaging with MR, CT, renal bladder ultrasound, and I add the renal bladder ultrasound because that's obviously in the hematuria workups now and important. So that's all non-muscle invasive. Those are the guidelines. Those are the key points that I think are important. I'm going to quickly touch on complications and actually the metabolic derangements. Complications for cystectomy are, I guess, pretty straightforward. This is one of the very original papers, basically from a large series describing the complications. They basically come under GI infection, cardiac, pulmonary, GU, and so forth and so on. I would say infection, general urinary, GI, and obviously the DVT, PE, MI, CVAs, those are sort of the more important ones. From my standpoint, things that may show up on your test that are important to consider: urine leaks, which is the GU part of those. If you have a patient who underwent cystectomy, has low urine output, has increased drain output, has a rising serum creatinine, all those types of things, you should really consider urine leak. Answer for a urine leak is always diversion. Do not go back to the operating room. Put a nephrostomy tube in or some type of stent that will bypass wherever the leak is. Extremely important to just remember that concept. Bowel, obviously ileus, small bowel obstruction, and a leak, extremely important. Patients who have a leak, you basically need to go back to the operating room. Patients with ileus or small bowel obstruction, you conservatively manage those patients. Patients who have a small bowel obstruction and it's a clear small bowel obstruction, clearly stated early on, let's say within the first week, you can consider taking those patients back to the operating room. But if you're outside that first week window, always, always, always treat these patients conservatively. NPO, G-tube, NG-tube, TPN, those are the things you want to look at in your question stems. And actually in real life practice. Mu-opioid receptors, so Entereg is obviously been on the test before, and can be tested. Important, that decreases the ileus rates. It's also important to make sure that you understand that patients who are on chronic opioids cannot get these. Those are the exclusion patients. Patients who have altered mental status post-op have very common, I mean, obviously because of the diversions, can very commonly have metabolic abnormalities. So make sure that some of the things that you ask for or you identify in your question stem in those patients are to make sure you get all the necessary electrolytes to make sure that they're an adequate magnesium, phosphorus. You get a BMP because of the various different acidoses. And obviously infections come to mind if you have some type of atypical presentation. If a patient is there's just something that just doesn't seem right with the patient, you want to just make sure that you put infection at the top of your list, and don't hesitate to get cultures in those patients because very often they'll have the infections. These are the metabolic derangements. Again, easy to memorize, but better to understand if you take the time to just learn what these different segments of bowel do. If you understand that the stomach has a potassium hydrogen exchange and exactly how it functions, you will understand that those patients who get a stomach diversion will lose potassium, and you get hypochloremic, and you get and because of the acid-base exchange, you get a metabolic alkalosis in those patients. So instead of trying to memorize this, really focus on understanding the function of each one of these bowel segments. And if you understand what these bowel segments do, then you don't have to memorize anything, because you just kind of can, step by step, think your way through what happens rather than just trying to memorize, because if you memorize, you will forget. That always happens. So really focus on understanding. I mean, the few things that I've highlighted here are the easiest things. Metabolic alkalosis is stomach, everything else is acidosis. Hyperkalemia is jejunum. Hypochloremia is ileum and colon. Very important for you to remember that ileum and colon, you lose B12, and then bicarb replacement. So those are common things that you may get tested on. But I encourage you to take the time to understand what these bowel segments do rather than just memorizing this table. Continent diversion no-nos. These are also questions that you may see. You never do a continent diversion in patients who have chronic renal insufficiency. What does that mean? It means a different thing to a lot of different people, meaning that you can put 3 cystectomy surgeons in a room and ask them which patient would they or would not they not do a continent diversion on, who have different GFRs, and you will get different answers. But things for the test that you need to remember are, forget about GFR, focus a little bit more on creatinine clearance. That obviously is more important because that speaks to what is being absorbed and what not being absorbed. And you want a creatinine clearance of greater than 35 to 45 nanograms per milliliter. I forgot to add the units there. An ammonium challenge is important. pH 5.8, just remember that. Or urine osmolality. So if you actually dehydrate a patient, that they're able to concentrate their urine, because those are the patients that actually will do fine with continent diversions. Hepatic dysfunction is another nice question, easily testable. Obviously, ammonium is excreted in the urine, and if you have a continent diversion, it can be reabsorbed. So questions that I remember seeing are, hepatic dysfunction in somebody who has a continent diversion, what do you do? And then you do catheterization, because that allows, it takes away the ability for reabsorption. And then the pathology questions, you will always see this in the cystectomy patients. So which patients should you not do a continent diversion on? Mostly speaking about neobladders in this case. Obviously, carcinoma in situ is not an absolute contraindication, but it is, patients are higher risk for recurrence. High volume disease, especially at the bladder neck, you should also be very cautious. Patients who have a positive margin, frozen section margin, you obviously should go away from doing an ilioneobladder. And then you should not think conduit, but if you can do a continent diversion, that is something that you want to consider. I think that's all I have for material. I'm happy to answer any questions or try to clarify anything that is not clear. I thought I would be under 40 minutes and I'm not 39 minutes, so I did what I thought I would do. So All right, no questions?
That was a really great talk, Dr. Sfakianos. Thank you so much. There are a couple of questions in the chat that I'll field to you here. Alex Lowe had a question about BCG. He said, does a second course imply repeat adequate course, i.e. four times total courses?
Does second course imply repeat? Yes. So so you have to give usually what you would see in this sense for this patient. So adequate is required for failure discussion, right? So that's patients get 2 induction or an induction plus a maintenance. Where we were implying for the second course is that if you have a patient who has intravesical BCG and has persistent disease or has a recurrence within 6 months, a lot of us in practice will say you already failed BCG, you should go to something else. But for the purposes of the actual guidelines and questions, you should always consider a second course of BCG, and then that would make it quote unquote an adequate course for failure questions.
Gotcha. Thanks.
Maybe it's sort of adequate. Mean that you will see adequate for failure. For like what is the next step? You will see second courses BCG in patients who had 1 course, and there's a couple of questions that I have that we will go over that kind of explains that.
Great. Greg Mullen asked if you send all of your patients who are going for cystectomy for neoadjuvant chemo.
Yes, Greg.
And Nathan Bloomberg asked, what about age and complications? I guess, do you make any special considerations for age when you are going towards cystectomy?
No. So there's been now plenty of data showing, cystectomy in octogenarians and, so forth and so on. An 80-year-old patient who only has hyperlipidemia versus a 54-year-old patient who has uncontrolled diabetes, cardiac disease, has had a heart attack with 4 stents, obviously are different, and age has nothing to do with it. So while a lot of folks will look at age as a comorbidity, it technically isn't. And there's plenty of literature now to support the fact that age shouldn't really be considered as a risk for cystectomy. So I don't think there's any true guidelines or questions that will come up from that sense. That's more of a practice question, the clinical practice question.
Perfect. Thanks. All right. Did you say you had a couple in-service questions to go through?
I do. Did you have them, or what do you want to?
I do not have them.
Perfect.
That'd be great.
All right. Well, we're gonna pick on random people here. I don't even know who folks are, but let's see who's paying attention. It's actually smart to put a picture instead of your name, because Courtney Berg. Courtney, are you on here? No, she doesn't want to answer this question.
Maybe we could use the raise hand feature. Maybe you could read the question out, and if someone knows the answer, they can use the raise hand.
I actually want them to choose. I want them to explain to me not the answer, basically.
All right. Regardless, let's use the raise hand and see if.
All right, raise hand. So, 71-year-old man has newly diagnosed carcinoma in situ of the bladder. BCG is currently unavailable due to a shortage. The next step is. So can anybody tell me, I guess it's kind of hard when we're in this and they're not my residents, because if they were my residents, they would all be entering. Or residents I work with, they're not my residents. So really I put this question on here because this was a question from one of the last CSAP collections. And I do have to thank Greg Mullen for collecting these and helping me because I don't have access to them anymore. So the important part of this question, and I guess I'll just go through them myself because just for the sake of time, but So basically, a newly diagnosed carcinoma in situ of the bladder. So this is a primary diagnosis. BCG is unavailable. What do you treat? This is a high-risk patient, and so the question here really, and where the stem is this patient fit or unfit for cystectomy? That's what's missing here. The other thing that's missing here, or the other thing that's confusing here, is that C and D are both intravesical chemotherapy. Valrubicin is actually approved, FDA approved for BCG resistant patients. Well, mitomycin doesn't technically have an FDA approval, but has been used historically in bladder cancer versus just waiting. And obviously a high-risk patient, you do not want to wait. You also, in the sense for, sorry, I'm just gonna, yep. You don't, oh, sorry, there you go. So you don't want to wait in the sense, or A and B are out. You do not know if the patient is fit or unfit, so you always want to play safe. And then you are stuck between two intravesical chemotherapies. And if you remember at the beginning, I told you there's really no difference between the chemotherapies. So I think this is kind of a bad question, because you can argue that you can use valrubicin up front, but the big difference is that there's FDA approval for BCG resistant versus not. So you should go with mitomycin. So a 75-year-old man undergoes a TURP for obstructive voiding symptoms. He was treated 3 years ago with 6 weeks of intravesical BCG therapy for non-muscle invasive urothelial carcinoma of the bladder and has not had tumor recurrence. The TUR specimen reveals BCG of urothelial CIS of the prostatic urethra. There is no evidence of ductal stromal invasion. The next step is, so obviously the ductal and stromal invasion, so that's what I'm focusing on in this question stem, because that's important. So this is superficial disease. The other part that I am really focusing on is the fact that the BCG was 3 years ago. So somebody who reads this question quickly can miss the 3 years ago and really lose the sort of the next question. The other important part of this is the TURP, right? So if you have prostatic urethral disease, you want to make sure you do a TURP to allow access to whatever intravesical agent that you're going to place. And so the fact that this was 3 years ago means that the patient had a good recurrence-free survival. So a second BCG is important. So this is one of the areas where a second BCG and a second induction BCG should be used. This is also, I think, an older question, because the idea of adequate BCG being 2 induction or induction versus maintenance is fairly a newer concept, and that's something that can obviously throw into a question like this. And radical cystoprostatectomy with uretrectomy, you obviously would do that if the patient had T4 disease, so if he had actual stromal invasion. You do not, high-risk disease, you do not wait on, you do not sort of do observation in those patients. There's no reason for a re-TURP, but for whatever reason, if this actually said biopsy and not TURP, then, and ask you what the best next step is, you may want to consider a TURP before doing intravesical therapy, again, for contact of that agent. So things and ways they can twist these questions. A 6-year-old man has a high-grade T1 urothelial carcinoma of the bladder. He receives the 5th of 6 weekly installations of intravesical BCG. 12 hours later, he has a temperature of 39.5, difficulty breathing, and hypertension. The most likely cause of this complication is, this goes back to what we spoke about. When you look and think about this, it's really about the BCG getting into the systemic or into the circulation, and what's causing these type of systemic effects of BCG. And what we spoke about is obviously the traumatic catheterization. You would not get these types of symptoms if it was still local disease. Impaired immunological state is what I kind of brought up before, because there are so many different definitions unless it is a very clear definition, really focus on the other answers here. So obviously for this, it's traumatic catheterization. It opened access for the BCG to get into the circulation. A 43-year-old man has a 4-centimeter micropapillary urothelial carcinoma that extensively invades the lamina propria near the bladder dome. Muscularis propria is present and uninvolved. The next step is, so again, it is extremely important to focus on what is being said here, right? So this is a 4-centimeter micropapillary. So this goes back into the varying histologies. And what is important about those variant histologies, how more aggressive they are than the pure urothelials. From that point, from that concept, you go to the actual question stems, and you really focus on what we have here. You focus on all aspects of it. So is muscle present or not? How big is this tumor? The location of the tumor, and how those things can change and can change what your answers are. From the concept of this specific, you obviously want to be extremely aggressive because you have the variant histology. So you want to really focus on the radical cystectomy. And this is part of the guidelines like we spoke about, the T1 high grades with the variant histologies. If for whatever reason this question changed, right, and said there is no muscle in the specimen, you obviously want to do the restaging TURBT. If whatever reason this was a 1-centimeter micropapillary at the dome, T1 high grade with muscle, you may consider doing a partial cystectomy in this patient. If this was a muscle invasive micropapillary cancer, you would consider neoadjuvant chemo because that does not change, then radical cystectomy. And so these sort of small little nuances in the question stems can drastically change how you answer the questions. And it's actually very important that you focus on those and you know and understand sort of the differences between how you treat and what the actual parameters are in these cases. So,
one quick question before you go on to the next one from Sharon. She said, if it were a 4-centimeter high-grade T1 extensively invading the lamina propria, then you do a restaging TURBT, right? I.e., you wouldn't even consider restaging TURBT for variant histologies like we do for the high-grade TA or high-grade T1?
If this is a patient who is fit for cystectomy, then yeah, you don't have to do the restaging with the variant histologies because the answer should be radical cystectomy.
And if it was not a variant histology, a 4-centimeter high-grade T1?
Then you do the restaging.
Okay, great. Thanks.
And if the patient has a variant histology but is unfit for cystectomy, and you will consider intravesical therapy, then you should do the restaging.
Got it.
Again, all these little nuances, I guess, that can change how you answer the question. And that's why reading the question carefully is very important. A 70-year-old man is undergoing a radical cystectomy and orthotopic urinary diversion for muscle invasive high-grade urothelial carcinoma. During lymphadenectomy, an unexpected 1.5 centimeter external iliac lymph node is confirmed to be a metastasis. The next step is, I put this question because this is also very important. The idea of debulking disease is something that I didn't touch upon when we were going over the material, but it is something important to consider as you're answering questions. Meaning that if you're in the operating room and you see what you think is a T3B cancer, so you have a tumor that has extravesical extension, coming into the fat in the peritoneum as you're doing a cystectomy, you really shouldn't abort that cystectomy. It's the same idea here in terms of if you have suspicious iliac nodes or suspicious lymph nodes, you really shouldn't stop your surgery if it is safe to proceed. If this question said something like encasing the iliac artery, or something to the point of making it dangerous to do the resection, then you stop. But otherwise, you really should just focus on completing the surgery as planned. The second part of this question and why it's important is that XRT really should, in the adjuvant setting, should really never be an answer, because it really doesn't have any data to support it. So again, just things to consider and remember. A 62-year-old man receives induction BCG for diffuse CS of the bladder. A cystoscopy 6 months later. At cystoscopy 6 months later, the optimal way to detect persistent or recurrent CIS is. This is a question I put on here because it is, when I was doing my in-service test, the answer was clearly cytology in this. But now you need to understand that blue light cystoscopy is here. It's here to stay. It's being questioned because the people who write these questions are the people who've done the trials. And most importantly, the one proven concept behind blue light cystoscopy is that it can pick up more CIS, more than papillary tumors. This is truly for CIS disease. And so if these questions have CIS, really focus on choosing the blue light cystoscopy as being that answer. This is what we kind of spoke about, and really I copied this when we were talking about the chronic renal insufficiency for patients. So it doesn't necessarily mean the creatinine itself under 2 you can always usually consider a continent diversion. Over 2 does not mean that you can't. It's more based on how the patient can concentrate their urine and how they're doing well with filtering. And it's just really understanding this and understanding the sort of concept of why it's dangerous to do a urinary diversion in somebody who has chronic renal insufficiency. And obviously that's because these patients can reabsorb and can cause acidoses and different issues that can lead to further complications systemically. And then this goes back to the continent diversion, understanding the different segments and what they do. What is the difference between a colon segment and an ileal segment, and why? A bowel obstruction is more common. That is not true. No matter small or large bowel, you have similar risk for obstruction. Electrolyte abnormalities are more common. So using a colon segment versus an ileal segment, Ilium can actually have more reabsorption than the colon, right? The colon is more water-based, so that is not true. It is more difficult to reach the urethral stump. That just makes no sense. Anti-refluxing anastomosis with tunneling is more difficult. That is also, some may argue that may be true because you have a thicker serosa and you have a thicker wall of the colon, but technically speaking, probably not. And nutritional problems are less frequent, and knowing that you have more reabsorption in the ileum of things like B12 and so forth, that would be the answer. So instead of memorizing a table, open up a GI or a Google and really understand what the bowel segments do, and then you don't have to memorize anything if you really just understand. A 61-year-old woman with continent cutaneous diversion develops cirrhosis. She's admitted with elevated transaminases and lethargy. The next step is, kind of mentioned this before also, really because you can get reabsorption in the urine, you want to make sure that there's continuous drainage. And in this case, you really just want to put a pouch. And I am shocked that I was able to get this exactly at an hour. And so that's it. But I'm not sure if there are any other questions or anything else that needs to be clarified, but I'm happy to.
Well, that was great, Dr. Sfakianos. Thank you again. There are no more questions.